because our next and last group of speakers for the day is a four-part. We have a panel of physical, occupational, and speech therapy panelists. So they will be able to answer a lot of your questions on maybe really important what not to do. Because sometimes we all think we know what to do. And there was a caregiver that came in today after lunch, and that caregiver said that they were late because they went to pick up their mom from therapy. Mom fell, and the thing was, I had to pick her up. Guess what we can't do at the senior center? We can't pick you up if you fall, because we might hurt ourselves, and we might hurt them. We might go back down. So there are ways to do it. 911 is one way, you call an ambulance, but these folks here today might be able to answer some questions. If you must, you're at home alone, or you just can't get, they may give you some tips. So we'd like to welcome these folks up here. So Carrie is from the VA, and Katie, you're from Wyoming, or from Sheridan PT, and the VA, okay. And Jeannie, you're from Wyoming Rehab, and Jeanette, you're from Sheridan Memorial Hospital Home Care and Hospice, right? I got y'all? Can I get another, maybe another, yes?
Can I have a question? I just want to know if there's one more door prize we're supposed to do, and I don't know if you can do that now or later, but I just want to let you know about that.
We have another door prize? And what is it?
Devoted to home.
Devoted to home. They're gonna come to your house and give you 24 hours of respite, right? Come on.
Or a gift basket.
Or a gift basket. But you know what? Devoted to Home is a great partner. They do provide off-hour respite care, both privately, but they work with the senior center with myself and my programs. And we really appreciate Shelley and her staff. So here's a Linda Brennan.
And I think she's gone already, but we'll
But we
keep
have
that
a phone number.
information.
All right, we have a phone number. Thank you, Shelley. Get your questions ready for these folks.
Hi, I'm Carrie Miller. I'm the occupational therapist at the Sheridan VA. One of our goals, as many people have mentioned today, engagement in life. As an occupational therapist, we try to engage people in the occupation of life, everything that they try to do in life, either through restoring it, compensating, or adapting it. There's lots of different ways you can do things, lots of different equipment that can help you out, and we try to help with all of those things. Speak up? Sorry. Do you want me to say that all again? All right. So I'm Carrie, the occupational therapist at the VA. As an occupational therapist, we try to engage people in life, do the things that they need to do the things they want to do, either by restoring it, adapting it, or compensating for it. There's many different ways you can go about things to try to maximize your participation in life, to improve that quality of life. Through changing it, adaptive equipment, or changing things. So there are ways that we can try to help out. If you would like to, you can contact your medical provider, and they can give you a consult for me if you're through the VA. If not, we do have other resources in our wonderful community.
Hi, I'm Katie Sherwood. I'm a speech pathologist. I work at Sheridan Physical Therapy and at the VA. And speech, if you ask any speech pathologist, they will tell you we're poorly named because a lot of persons' speech is excellent, but they come to see us because they have swallowing difficulties or difficulty with memory, difficulty with expression. Some persons who've had strokes often come to see a speech pathologist. And just as Carrie said, if you have a loved one who's had some difficulty and you'd like them to see a speech pathologist, just talk to your doctor about it. In the past, we've certainly had some aphasia support groups. Some of those have been for persons who have aphasia. Others have been for the caregivers who love the persons with aphasia. But I don't know right now that we have any going on, but if persons are interested, I'm certain that speech pathologists in the region and other folks would be happy to re-engage those, and many other things, but I won't hog the mic.
Hi, I'm Jeannie Brooks, and I'm from Wyoming Rehab. I'm a physical therapist, and physical therapists address a lot of functional things for people. For example, we help get people stronger who have gotten weak. We help with balance problems. We help with flexibility and just functional movement, walking, balancing, being able to go up and down stairs, maybe get in and out of a car, functional things that you would do throughout the day. We also help with things that you may not be aware of. We help with wounds. We help with swelling. Sometimes when people are not as active as they once were, they can develop swelling in their legs that we call edema or lymphedema. We offer treatments for that, and it's important to catch it early and to address it before it becomes a bigger problem. I'm at Wyoming Rehab, and I think that this is probably offered at the other facilities as well, but we offer free screens. If you have a loved one or yourself, if you've acquired an injury, you can just come right into Wyoming Rehab, and we can take a look at that injury and give you guidance. And we can also help with giving you some tips or some training in how to work with your loved one or your client at home, helping with transfers, helping with bed mobility, and helping with functional activity. We're here to help, and we want to help.
Hi, my name is Jeanette Asby. I'm an occupational therapist with home care and hospice from the hospital. So I go into people's homes and assess if they have any equipment needs or help to try and make suggestions to reduce a person's fall risk, or help to recommend other community resources in town so that a person can manage more safely and more independently. And I can also be sometimes a little bit of a jack of all trades, because sometimes you just go into a home and a person can't really say what's exactly wrong, but they can say they're struggling with this or they're struggling with that. So I like to look at a whole person's schedule and their home environment. Are they able to, are they doing things consistently on a daily level, on a daily basis? Or are they just kind of getting up whenever and taking their meds whenever? So I try and look at maybe establishing more of a routine for people. Whatever issue arises, sometimes it's not just a physical need, sometimes it's just, I don't know how to get my groceries because I can't get out of the house, as simple as that. So it's just there's all sorts of things that any of the therapies can do that are not just exercising or walking or using your hands. So it could be very helpful in all sorts of capacities. Anyone have any questions?
The second gal.
Katie?
Katie, you mentioned that you also work on memory things. What does that involve?
Absolutely. Speech pathologists often work on memory. Memory, it has so many parts to it. We often talk about long-term memory versus short-term memory. Usually short-term memory is more a problem for persons. We also have what we call working memory. It's kind of like where you have to hang on to something for just a minute. Kind of like one of the things I give people, I might give 3 words. I might say ball, flag, and tree. What was the second word? And you don't need to remember any of that. You're just thinking, what was it? It was flag. So then you think about it. But I certainly work on people, sometimes to enhance their memory or help it, sometimes to compensate for the loss. Sometimes a memory isn't coming back, but a person will utilize electronic means to help them. Some people love their cell phones, some people hate electronic means, and they use calendars, and we all use compensatory strategies with memory. I certainly have a calendar today that said I would be here today at 1:30 so that I wouldn't be late. But certainly a speech pathologist works on memory, usually after someone has had a stroke or a brain injury, but also with persons who've had dementia or Alzheimer's dementia or different things. Did you have a specific question?
You work with the VA also?
Yes, I work at the VA part-time and at Sheridan PT part-time.
Thank you.
You're welcome.
So I'm so excited to hear you say that. So help me walk through this, because I'm one of those people. So I noticed there's some memory problems, maybe with my person who might be, say, 80 something or 90 something, and maybe not part of the VA. I can call you, or do I talk to my doctor first? I mean, is this something that Medicare could pay for, or is this me? If I was a child caring for my elder parent, and I'm listening to you right now, and you got my number, what would be the best route for me to start this process?
Usually to contact one of your referring providers, whether that's your doctor, your PA, your family nurse practitioner. And Medicare definitely covers speech pathology to cover memory. With speech pathology, with language, we have expressive language, being able to say what you want to say, and receptive language, being able to understand what is said to you. And there's a lot to that. There's processing, I know exactly what I want to say, but I can't get it out, or there's something went in, but it didn't stick. And we kind of talked about encoding. It's something we hear stick, and decoding. Can I then process how I want to respond and say it? But as far as how, if you're thinking, ooh, that sounds like someone I work with, or that sounds like my mom, if you could contact that person's referring provider and say, hey, could we refer this person to a speech pathologist, if it's at the VA, you're going to get me. If it's Wyoming Rehab, you get the lovely Tempe Murphy, or Sheridan PT, me again. But there are a handful of us, and then each of the skilled nursing facilities certainly have speech pathologists who work on memory. So referring provider would be wise.
Something to add? So if you have a family member also that is living at home, maybe by themselves, or you're living with that family member that is having memory problems or issues, or you have concerns, if that person, if they're struggling to also get out of the house, or to go to different activities or places in the community, that's also a potential referral for home care. So you can have therapists and nurse, speech, OT, PT go into the home if they're not able to get out of the home. So if you're feeling like you have a family member that's stuck in the home but needs help, you can get help at home. And if you feel that if that family member can get a ride to a facility, they can also get services and help in an outpatient clinic or at the hospital, or there's different agencies.
Any other questions?
I probably don't need a mic, but I'll use it. It's for any of you, and I guess I want to know if the VA does this as well, but most of the Wyoming Rehab, Sheridan PT, and other outpatient PT places help people with maybe adjustment of crutches or a walker. We at the hub, we have a loan closet, and so we have a lot of adaptive equipment. But people often don't know what they need. They just know, my wife's going to have surgery. My mom just got out of the hospital. I need a walker. Well, do you want a two-wheeled, a four-wheeled, a no-wheeled? They don't know. And so they pick something that might not be appropriate. So I really try to say to them, if they don't have therapy that they're going through, to see one of you places. Because you have been very helpful in just adjusting things for people without a fee. So is that something that is it okay to do a walk-in? Tell us a little bit about that, please.
That's it. That's a great question, Stella. And yes, that is a service that we provide at Wyoming Rehab, and I would be willing to bet that Sheridan PT does that as well. We welcome people coming in anytime. If you have questions about, for example, walkers or canes, we're happy to give you input about what type of walker or cane would be helpful in your situation or in your loved one's situation. We're happy to adjust that equipment to fit your loved one or your client. We definitely, that's right down our alley, so we're really happy to help you with that. I wanted to also let you know that if you or a loved one or your client is preparing to go to surgery and you're of the mind that they'll probably need a walker afterwards, we also at the hospital, Wyoming Rehab is actually a department of the hospital, so I work at the hospital and I work at Wyoming Rehab, so just to cut the confusion there. If you do plan to go in for surgery, and after you have your surgery, you'll be seen by a physical therapist there in the hospital. And as Stella mentioned, you can get a walker or a cane from their loaner closet prior to going to the hospital. Or another option is at the hospital, we can actually give you a walker if you'd like, and then that's billed out to Medicare or to your primary insurance. So if you're wanting a new walker, that's another option. And there's obviously also the option of picking a walker up at Walmart or the hospital pharmacy or the different pharmacies in town. So there's several options there. But yes, we are there for you if you want to come in and have a walker fitted.
The nice thing through with the VA, if you are a veteran, we can also get all of that equipment. We also have the extra benefit of being able to get other things that you might not be able to get through Medicare, such as shower chairs, grab bars, adaptive equipment such as long-handled reacher, shoehorn, sock aids, all those things that you might need in advance of pending surgeries beforehand. And if there is something after, we can always look through those to see what would best fit your needs.
I just have to say, one of the things that the VA has done for my almost 95-year-old father-in-law, the audiology department he has hearing aids, but even with those, he can't really hear the TV without cranking it to blast us. I mean, I heard it coming from the barn one day. So what they did is, it's a thing he wears around his neck, and then he wears like headphones, and he can control that and hear that through his ears without blasting everybody out of the house.
That sounds like a pocket talker is what those are called. There's also great things with hearing aids that are a lot more advanced now that you can connect through your TV, so the TV will come through your hearing aids. Smartphones can come through your hearing aids that the audiologist can get through at the VA also, or here in town also. And telephones. There's so many different types of adaptive equipment with the captioning and low hearing, low vision.
I work up at the greenhouse. One of the ladies that lives there has a phone that has a caption thing. And I keep thinking, well, that would be wonderful for my father-in-law. But then, every now and then he gets phone calls from telemarketers and he doesn't answer them. But it would still, so the VA can provide that phone, or we could get it or not.
I believe that they could with, certain diagnoses as long as, they would qualify for it.
I think that's the one thing he has qualified is the hearing aids thing because he worked on plans in the Navy. So I would just like him to
And that could be provided through, the audiologist would be the best one. They're a lot more familiar with that type of equipment for low hearing, but Katie probably could, I could too, help with some of that stuff if the audiologist can't.
And maybe the phone company, I don't know if that's something they can
That is, again, I'm not all that well versed in some of that, but I do know some of that equipment, there are sometimes a certain fee that you might have to pay for that captioning services, but I think that they are leaning more towards that it's immediate transcript and it's more computerized, so I'm thinking there might be an easier way now.
One little trick I've used before is, so if it's not a vision issue, but it's a hearing issue, I've suggested to people to just turn on the speaker instead of picking up the handset. I had a lady that could not talk on the phone. She couldn't hear everything, so she wouldn't talk to her family anymore. So I suggested she use her speakerphone on her regular phone, and she hears everything, and it worked really well for her. So I find maybe just on a phone you just have that little radius of noise, but on the speakerphone it kind of, the volume kind of fills the whole room a little bit more. So I found that was a good trick for one of my clients.
I was just going to say also, if you have an iPhone, there are TTY services for iPhone.
My guy has hearing aids in both ears, has a problem with telephone calls. So the VA Audiology has hooked him up with a device called a Bluetooth that's into his telephone, and when it rings and he answers it, he can hear it in his hearing aids, not even have to pick the telephone up to talk or hear. I think it's fantastic.
So I just wanted to say, or just piggyback on what Jeanette was talking about, and something that I have a little bit of awareness about is that with dementia or another progressive situation, sometimes there might be a little resistance to asking for help as things progress. But oftentimes, what I hear you saying in this one instance is there's going to be new things that happen, and so it's acceptable to keep asking for help at different phases. And I just wanted to ask a little bit, I guess a question about, are you starting to see this happening? Maybe not so much in just a dementia situation, but do you feel that our community understands how to access you and understands that with progressive situations, they will need to continually ask for help for the new that's always coming?
I think there's just a general increasing of understanding about services that are offered, and I think there seems to be more understanding, but there is also a need for more understanding and more education about what's offered in the realm of healthcare in general. But us all being therapists, we do see that there's a need for more education. Because a lot of people just aren't aware of what's out there, and especially in the areas of prevention. I think a lot of times people think of therapists, physical therapists, occupational therapists, and speech therapists as being helpful after there's a problem, like after there's an injury, or after there's an illness, or something like that. And what we'd really like people to know is that we can get involved much earlier than that and help to prevent injuries, help to even prevent illnesses, or increase people's ability to handle illness, or say cancer in particular. One example is that we have an oncology rehab program, and so for people who are diagnosed with cancer, I think one of the big problems is that people tend to think, oh, I have cancer now, and it's just going to be they might have a dreary outlook, like it's going to be a downhill slide, or now I'm sick, and they have a kind of a feeling, an emotional feeling about that diagnosis that, gosh, life is just not going to be the same anymore, and I guess I'm just not going to be able to do what I've always done. Well, I want to challenge everybody in that way of thinking, and for our loved ones, for the people we're taking care of, for our clients, that I think that's an unproductive way of thinking, and I'd like to encourage you to seek out the help that's available. Physical therapists, occupational therapists, speech therapists have a lot to offer. Certainly when somebody's diagnosed with cancer, for example. There's also a lot that we can do prior to diagnosis or prior to an injury. If you see that your loved one is, say, becoming weaker because maybe they're becoming more sedentary, maybe they're not doing what they used to do, that's a great time to bring in a therapist. We like to help motivate people, we like to encourage them, we like them to be just vibrant and to be able to be active in their life. Losing strength and losing function is not a normal part of aging. We can continue to be very strong and very active all through our lives. And we want to have that mentality that even though maybe we have an illness, or maybe we have had an injury, or if we haven't, we can still do things to keep ourselves strong, to get stronger, to be more functional, and therapists are quite good at that. That's what we're trained to do. And so, in a nutshell, if you have a client or somebody in your life who you notice that they're just not living life as to the like they used to, and they're losing function or losing strength, consider bringing them to a physical therapist, an occupational therapist, or a speech therapist, depending on what their problem is, and let's give them kind of a new lease on life. Let's get them through these rough spots and over the potholes and get them back to high function. Yeah.
You mentioned also that you have a wonderful person who works with Parkinson's exercise.
Yes. At Wyoming Rehab, and I know Shared PT does too, we have a very wonderful program called, it's just called LSBT Big and LSBT Loud. And I know that's kind of a weird name, but it's basically a Parkinson's program that is phenomenal. We take people who have become pretty incapacitated by their diagnosis. They start moving slower and smaller movements. You shuffle along when you instead of walking normally with Parkinson's. We start talking quieter instead of talking, more loud and open. And this program called LSBT Big, which is the physical therapy component of it, and then there's LSBT Loud, which is the speech therapy component. We can get people moving again. And the results are amazing. I've been floored by how amazing it is for these clients. They come in moving in very small movements, and they leave after a few weeks of therapy. Usually it's about 8 weeks of therapy, just walking much more normally, moving more normally. Their emotions become, quote, bigger, and that's why they call it LSBT Big, because they're trying to help them to move bigger. And then with regard to the speech component of it, Katie can probably tell you more, they start talking more normally, and we really can do a lot with our Parkinson's patients, and I think a lot of people aren't aware of that, but we really want to get the word out. There's so much more for these folks. It doesn't have to be a downhill slide.
I can tell you a little bit more about LSBT. It was Lee Silverman Voice Therapy. It's been around for more than 20 years and has extensive research and data that proves that it works, so it's really wonderful. But also related to your original question when you spoke about progressive diseases and possibly persons coming to therapy, I would say oftentimes we give patients and our caregivers a lot of knowledge about what's coming. So if someone has mild dementia, or they've been diagnosed with Parkinson's, but they're still getting around well, and they're still talking really well, swallowing well, but if we kind of plant the seed that things are going to change, then it's not as big a shock when a person has to say, now I have another question, because something changed. So therapies can be really helpful in educating not just the person with the deficit, but with the caregivers and the family members, the loved ones. Because sometimes, it's shocking when you hear a diagnosis and your referring physician or referring provider may have said, this is going to happen and this might happen and be aware of that, but you're in such shock and you don't remember what was said at the initial meeting, then they send you to see one of us, and I often tell people, I say, you may have heard this from Dr. So-and-so, so it's better to hear something twice than not at all. So then I repeat often what they said, but the other thing is we often have an hour with the person, or an hour 3 times a week for 6 weeks, so we can really pass on a lot of information to people. And your referring provider, you might get an hour, you might get a half hour, you might get 15 minutes, but therapy can really help with questions that people have to really better explain, what might be happening, what's going on, and just kind of help people move forward. Any other questions?
Back to that other lady, when you were talking about that your activity level doesn't have to decrease with age. I'm seeing that with my dad, and he's just not as active as he used to be. And if it comes from me, it's almost like he doesn't, it's like he doesn't see it, but I see it. Is there a way to go around that? As far as, like, if somebody, can I call you guys and it can be kind of a, I don't want to say to trick him, but yeah, if it comes from me, if it comes from me, it's like,
I totally get it, yes.
Yeah.
Usually, loved ones are the ones that are just the dumbest people. They just don't, it comes a lot better from somebody on the outside or quote a professional. And so one of the easiest ways, I think, to get, maybe your loved one into a therapy regimen is to go through your doctor. That's probably the easiest way, because typically if a doctor says it, then it's golden, and it's the kind of the gospel. So I think that's the best way to go about it. I think that's the best way. You can also come into any of the clinics. I know at Wyoming Rehab, you can come in off the street, you can have a screen, a therapist can talk one-on-one with you and your loved one and kind of give some ideas or some direction as to what we have to offer, or what therapy in general has to offer. So, but doctors are a great way to get into a therapy program.
Thank you. I can add a little bit. Sometimes you could, your family members, so let's say they used to go for long walks outside, or they used to go for rides, or they used to go to the shop and do some woodworking. If there's things that you're noticing that they're not doing anymore, you can possibly say, hey Dad, would you like to be working in your shop again, or going for walks more? And if they say, yeah, that'd be good, but I can't go, you could say, well, maybe we could go see someone and they could help you so you can go to the shop some more, or walk outside, or be able to get to your car. So I find that if you can just find something that they want to be able to do that they're struggling with, and you make that connection with an agency or other therapists through your doctor, that could be, you don't have to do all the explaining, or you don't have to say, you can't. You can say, oh, you can do that. You just maybe need a little bit of help, and I know someone that can help you with that. And then leave it up to the therapists and the doctors to kind of work their magic and get them motivated to want to, do better for themselves. Because it's hard to have a family member just say, you can't do this, you can't, I can't do this, or you can't do this anymore. So instead of pointing things out, you can just bring them somewhere.
Kind of to dovetail with what Jeanette was saying too, I think there's, if a loved one is having more difficulty with movement or doing things that they used to do, and maybe they've fallen or they've injured themselves, and I think one of the natural reactions for us as caregivers or as family members is to be more protective, maybe allow, kind of say, oh, you probably shouldn't do that, or or maybe you should sit down, or maybe we need to get a wheelchair. Just there's these different thoughts that go through our minds. And I think if you're starting to think in those terms, that's another reason to get the doctors involved, get a therapist involved, because we really do want to keep people as active as possible throughout their lives. The more active we are, of course, the less likely we are to get sick, and the quality of life is so much better. So that's just kind of another plug where therapies can help out and really help with quality of life and safety and all that good stuff.
I'll just add a little something just before you ask a question. So no matter what the age is or what the condition is, you could always improve and things could always get better. Essentially, that's our motto. You can always get better in all of the disciplines.
Absolutely. It's never too late to get stronger. It's never too late to improve your balance or become more active. That's always an option.
So I'm really excited about this conversation, and I'm excited about this bridge, because sometimes in dementia it's hard for a person, because they become a little less active, maybe because their executive function isn't working as well, so they're not initiating. And I think there can be a tension at times, and understandable, between care partners or community or neighbors and friends who are saying, come on, let's go do something. And that person may not be able to initiate or might actually be resisting. And what I'm excited about in this conversation is it's hard to know why a person might be resisting. If it's the cognitive change, or if there's a physical something happening. And so I'm very excited about this conversation and about the possibility of anybody in this room utilizing their healthcare professionals and you, in the sense that oftentimes there's going to be a communication breakdown. And there's a lot of technique and understanding you have behind the years and wealth of your knowledge that I think can really help care partners, whoever they are in the community, help their person they're caring for, because it's so hard for them to articulate where they're coming from and what they need. And so this science that you have like some sort of special eyes. You can look at a movement and you can see, oh, that's the hitch there. And so I'm just really excited about that you're able to talk to us about this and make yourself accessible, because this, in what we do at Dementia Friendly America, is a large piece of our puzzle. It's getting all of the providers in the city together and letting care partners know how wonderful and valuable everything we already have is.
You said something that really struck a chord with me, and I love that you said this. Sometimes things can happen in our lives and it can seem so overwhelming, but if you are put in contact with the right person, lots of times they can say, no, this is easy. We can fix this. It's not that big a deal. And so that's another thing to encourage all of you in, is that I think if you're isolated and you're kind of at home and in your own life, like we all can tend to do, especially when there's difficulties that come our way, it's kind of easy to assume that I'm kind of alone in this situation and there's just no hope because this is just how things are going to go because I'm getting older or I'm sick or whatever it may be. I want to just encourage a change in thinking there, because there's a lot out there to help in these situations. You're not alone, and each of us up here, we're all educated in function and motion and being able to do activities that are normal to every day, and we're versed at that. We know how to help people get over the humps and to help caregivers and to get to a better quality of life. So don't suffer in silence. Get out there and ask some questions.
I want to add a little quib for occupational therapy. As Heather mentioned, the TPIS know maximizing your engagement in life. There's, you know, sometimes things might be hard. Maybe it needs to be adapted, change a way for that loved one, especially with Alzheimer's and dementia, to continue doing something that they find enjoyable and that can help them pass that time and get more purpose out of life. Life should be purposeful. It should be fun. You have to find that engagement of things that you can do that gives you that good quality.
And then I would say, related to the communication, caregivers are so important, especially in speech. I can speak for myself. Letting us know what your loved one used to do, like to talk about, wants to communicate about, and to whom, so that we don't pick a random activity that hopefully would be helpful, but if it's also meaningful to the person, it's great for us, it's great for them, it's usually great for you. But it's really important with communication to be communicating about something the person wants. And then another thing, I suspect you all do it well, but certainly as professionals are reminded of it often, to be very respectful, even if a person has dementia and is not necessarily going to be helped back to the person they had been, but helped toward their future, that we might all continue to respect them and be very respectful in working with them. Because sometimes a person can be felt they're talked down to because they don't understand as they used to, or they don't communicate as they used to, but being respectful is huge.
Did you have a question?
Yeah, I'll try to yell at you. My sister-in-law has eating difficulties, but she has an arm like this, so she can't get down to the table to reach. And I was told by somebody, actually something I saw on Facebook, that they've got an adaptable spoon that's a swivel deal like this. And I was thinking about getting one from her, but I don't have an extra $200 to buy it with. And I don't know if there's a resource place to maybe find out about some of this adaptive silverware that people that have
Seniors
children. Do they?
We have.
Okay. Well,
There's
that's
a
what
lot of different type of adaptive equipment, and the swivel spoons that you're mentioning, those are usually more if you have tremors, and it can make it hard, but there's angled spoons, there's built-up spoons, there's longer spoons and forks, there's rocker knives, there's many, many different styles of adaptive equipment and utensils that can improve that ability. You know, if it's loss of strength, if it's loss of range of motion. And that could be something that you could ask the medical provider and tell them that they're having problems feeding themselves and would probably benefit from an occupational therapy consult to be able to get that food in the mouth. Once it's in the mouth, then it's her duty.
So I was going to add too, I know in my work with dementia caregivers and the people they're caring for, if there's any changes in eating, so maybe the actual eating part is okay, but there's a change in the diet or the appetite, and there is a diagnosis of dementia, I often do ask for speech consults or OT or dietetic consults because of the different ways that the brain can impact eating beyond that mechanical aspect. And so I just wanted to let people know that that's a resource too if there's a change in appetite with somebody with dementia.
Kind of like Carrie said, from here to here is definitely OT and trunk control, and we got PT too. And then as far as the swallowing mechanism, sometimes persons' intake changes greatly because things are more difficult to swallow, but they don't necessarily know that. And a swallowing consult or a speech pathology consult can be very important to know. Oh, no, I'm good.
One thing that research has shown is adding contrast to make that plate stand out can be beneficial to help just bring that attention to the food. Sometimes it's needing smaller portions to get them to motivate. If you see a whole big plate of food, it's like, whoa, I'm not going to be able to eat that. I don't want to eat any of it. But if you give them a little bowl full, sometimes they're more likely to eat that portion. Then you can fill it up again with something else. There's lots of different ways to try to improve that intake
of the food.
I'm just going to get back to your question and comment about your family member and her arm.
Put your mic up.
Oh, sorry, thanks. So if that person is having trouble feeding themselves, highly likely they're having trouble doing a lot of other things. So we could probably give you 15 items to try with her. But my first recommendation would be have her see someone, because we would be able to help identify other problems, other issues, and get to the most accurate and appropriate piece of equipment. Because it's hard to just, or it's easy to say you could use this, 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 and this, but in actuality, maybe there's something we can do with the arm so that the arm is not stuck there. So that person is definitely ready and appropriate to see someone for referral for therapy of some sort. And it could be occupational therapy, it could be physical therapy. You know, depends on where, if your family member can leave the home, and if she can, then you could easily just say to the doctor, she's having trouble feeding herself and a couple of other things, and the doctor would give a referral to either go to an outpatient clinic, or if they can't get out of the house, refer for home care, or if your family member is a veteran, then refer to the VA. So there's help in it. Sometimes we think that's just a little problem, but there's probably several other problems linked to that, because that's, you know, there's eating, there's answering the phone, there's multiple, you know, brushing your teeth. So it's probably just the beginning of, or just one symptom of probably a bunch of other issues that that person's having. But, you know, even if you think that's, it's just, she's just having trouble eating, you know, I don't need a therapy consult for that. I would say yes, it would be a great time, just like Jeannie was suggesting, to, you know, go see someone early before there's 10 big problems instead of just one. It's totally appropriate to go to get a referral or a consult for help.
The mic runner has a question. Could you perhaps speak about proper, like, for as far as mobility and torso, and I mean trunk control, how to have a proper like chair, or how to properly sit to provide the most support for someone who's maybe kind of, what triggered this idea or question was we were talking about eating. So what would be proper like seating for someone? Just a question.
That is a great question, and actually that's interesting you asked that question, because that question is actually very central to some things that we work on, specifically chronic pain, like people who have back pain or spinal related pain, neck pain, headaches. It goes back to posture, and it goes back to trunk control, trunk strength, and proper seating. And so I'm glad you asked that question, because it's kind of a big deal, and it affects a huge population. So just in a nutshell, it is best to sit in a chair that promotes good posture. And so, sure. So yeah, so Jeanette can be my, it's kind of fun. Okay, so we want to, when your loved one or you or anybody is sitting, we want to look again at good posture. Now, good posture is basically not this. You'll notice here that she has kind of a C-shaped posture. She's kind of rounded, and I always say C-shaped postures are catastrophe ready to happen. C for catastrophe. We actually, the good posture would be sitting up straighter, and I scoot your bottom back to the back of the chair, and we like to have more of an S-shaped posture, where she has an inward curve here at her lumbar spine. Having a little lumbar support is very important, and that creates that supports that normal S curve of the spine, which I say is super. and it's also safe. So having that safe posture helps with a whole myriad of things. It first of all will help your loved one not to acquire back pain or neck pain or even headaches. Migraine headaches lots of times have some roots in bad posture. It also will help with things like Katie can probably jump in and talk about. It would help with your swallowing and your ability to clear food, and it helps with digestion, circulation. It helps with your ability to actually use your arms. Interestingly, if we have really bad trunk control or bad posture, it affects our ability to move our arms well, because our arms work off of a stable base. And if we have good posture in our trunk and good strength in our trunk, then our arms have more ability to work functionally and also have more strength. It's all a very connected situation. So going back to the type of chair that you should look for would be a chair that has a firm, level seat. You'll find that most chairs do not have firm, level seats. In fact, I don't know why therapists were not consulted when chairs were made, but most chairs have a tilted seat, and it throws you back into that C position, which again is catastrophe waiting to happen. We like to have a level seat and firm. It doesn't mean it can't be padded, but we just don't want to be sinking into our seats and getting into that slumpy, rounded posture. So firm, level seat is important, and vertical back is important. Now, most chairs you'll find do not have a vertical back. They have a reclined back. And so what that does is, again, it throws you back into the slumpy posture, which affects your ability to move your arms. It causes pain, and it causes weakness, and lots of crazy things. So vertical back, level seat, and back support. The lumbar roll is good. Anything else? You can see I'm kind of into this. I love that. I work with chronic pain patients. And feet flat on the floor. So you don't want a chair that's too high where your feet are dangling. It's not real comfortable, and it also doesn't help with your posture. So height of the chair is a good thing to look at. Seat depth also is good to look at. You don't want to, I see lots of times little tiny ladies sitting in great big recliners. And so that ends up putting you into a more slumpy posture. So you want a chair that fits you, so that the depth is not longer than your thigh. Anything else? Okay. Does that answer the question? Okay. Dining room chairs are typically good chairs to sit in, and captain's chairs with arms.